Okay. A 55-year-old with a neurological condition which initially started with symptoms of urinary incontinence, erectile dysfunction, and dizziness when standing. He's seen to have signs and a slight tremor in his hands and a slight tremor in his feet. Huntington disease, Parkinson disease, Drager syndrome, Lewy body dementia, Creutzfeldt-Jakob disease. The screen has disappeared, Dr. Shah.
Is it visible now?
Yes. So, Parkinson's along with so it's the Shire-Drager syndrome.
Dr. Murat's answer is Shire syndrome. Whatever anyone else have to say. So yes, patient with the features of Parkinson's disease, dizziness when standing, which is postural hypertension and urinary incontinence. This is most likely Shire-Drager syndrome. So Dr. Musa is right. And I must say that you are doing excellent today.
Thank you.
So let's do one last question and then we'll start our who will read this question. Okay, I'll read this one. A 35-year-old lady presented to the clinic complaining that recently she had a number of funny doors. She describes a sensation that her surroundings are unreal, like a dream. On further questioning, she mentions that following the dream-like sensation, she starts to smack her lips, although she has no recollection of doing this. What is the single most likely diagnosis?
Is it
So a 35-year-old lady, yes.
focal impaired awareness seizure?
So Dr. Chafra is saying that it's focal impaired awareness seizure. Can you tell us about some points which are favoring this diagnosis?
I guess the lip smacking and the reason that she wasn't aware that she was like
Yes,
she's actually been having these episodes and the
lip
dreamlike
smacking
state.
means, yes, lip smacking means that a part of her body is involved and not the whole body. So it's definitely a focal seizure. And also as she has no recollection of the event, So yes, the awareness is impaired. So it is focal impaired awareness seizure. Let's do another one similar to this. Can anyone read this question?
A 63-year-old woman inpatient with a known history of epilepsy is having a seizure. The nurse who saw the seizure says it started by affecting her right hand before involving her entire right arm and then progressing to a loss of consciousness with her entire body shaking. What is the single most likely diagnosis?
Is it generalized tonic-clonic?
Remember that the diagnosis will be made on the basis of uh, at the onset of the seizure, where the seizure started. As the seizure started in her right hand, so it is a type of some focal seizure. And then later she became unconscious. So the seizure started in her hand only. It means only a small area of the brain or one organ or group of muscle was involved when the seizure was started. So it's less likely that it's a generalized seizure.
Is it Jacksonian march with secondary generalization?
Yes, it is Jacksonian march with secondary generalization. Uh, what are the points in favor of this diagnosis?
The points are that, when the nurse saw her symptoms first, it started affecting her right hand, then involving her entire right arm, and then it later progressed to the entire body shaking. So it's like it started from a focal point, and then there was a
In
march,
yes, it was like marching to other
march of
areas of the body.
motor. Yeah.
So yes, it's a Jacksonian march with a secondary generalization. Jacksonian march is also a type of focal seizure in which the seizures start in uh, one part of the body and then it start moving to the other parts of the body. That's why it is called Jacksonian march, because it marches towards other parts of the body. So now let's discuss some theory related to Jacksonian march and focal impaired awareness seizure. Because these topics were not present in Plab piece. So there's a separate slide for the discussion of these seizures. The new classification or classification of a seizure is basically based on three key features: where seizure began in the brain, level of awareness during a seizure, and other features of seizure. So on the basis of this, we will classify the seizures. Where seizure began in the brain. Does the seizure begin in the focal area, or was it started in all of the brain? If it started in a small area of brain, then it will be focal seizure. And if the electrical activity started in both of the lobes of the brain, then it will be generalized seizure. Focal seizures are divided into, as we discussed in the Plab keys, that focal seizure can be focal seizures. The other name for focal seizure is partial seizures. So partial seizures are also known as focal seizures. Now, focal seizures can be, there are two types of focal seizures: simple focal seizures or simple partial seizures, in which the awareness is not lost or there is no loss of consciousness. So, partial simple seizure, the other name for partial simple seizure is focal aware. The new name for partial simple seizure is, or simple partial seizure is, focal aware seizure. And a focal seizure in which there is loss of consciousness or awareness, it is known as focal impaired awareness seizure or complex partial seizure. So the new name for complex partial seizure is focal impaired awareness seizure. So these are two important points. The new name for partial seizure is focal seizure, and the types of focal seizure is, uh, or the partial seizure is, focal impaired awareness seizure and focal aware seizure. Focal seizure in which a person is aware of the event or there is no loss of consciousness, it is called focal aware seizure. And in which there is awareness is impaired, it is called focal impaired awareness seizure. Now, focal seizure can be classified into as being motor, such as we have discussed an example of motor seizure, like the seizure started in the hand of the patient and then it involved the whole arm of the patient and then it involved the whole body of the patient. So this is a type of focal seizure which we can call as motor seizure. Example is Jacksonian march, and we have done a scenario on Jacksonian march as well. They can be non-motor. Focal seizures can be non-motor as well. The example of non-motor is also done, in which the patient has dream-like sensation, and after that she started smacking her lip. This phenomena of lip smacking is known as automatism. We can pinpoint the lobe of the seizure from the sign and symptoms. For example, if the patient is having hallucinations, hallucination can be auditory, gustatory, or olfactory, or epigastric, a feeling of epigastric rising, or the phenomena of automatism, such as lip smacking, or the phenomena of deja vu. If any of these is present during a seizure, then we will say that temporal lobe is involved. So hallucinations, they can be auditory, gustatory, or olfactory, epigastric rising, and automatism or deja vu. If any of them is present, then we will say that temporal lobe is involved. And if it's a motor seizure, we all know that motor area is present in the frontal lobe. So if it's a motor focal motor seizure, then we'll say frontal lobe is involved. And sensory areas are present in the parietal lobe. And so if there is paresthesia, then we'll say that the origin or the location of the seizure is in the parietal lobe. And occipital lobe is associated with vision, so there will be visual symptoms in case of occipital lobe seizures, such as flutters or flashes.
Question.
Yes.
Are we going to do a scenario involving the deja vu? I'm just curious how that would play out.
In the scenario, I'll see if I find a scenario on deja vu. But in Plab 1 exam, they will most likely describe the deja vu type of scenarios like that. That the patient will say that uh, he experienced this situation before, like
Right.
the situation he was having during the seizure. He will tell that he feels like that he experienced this situation uh, before that as well.
Mm-hmm.
So this will be the kind of scenario. I'll see if I can find a question on this, and if I find it, I will put it in the neurology mock exam as well. Is that all right?
Yes, that sounds good.
Akshay, can you please repeat all that once more? It's not striking to my mind.
Uh, First of all, you need to understand focal seizures, that they will start in small areas of the brain. The other name for focal seizure is partial seizure, which will involve a part of the body or only one organ or part of the body. So they are called partial seizure, and the new name for partial seizure is focal seizure. Now there are two types of focal seizures. One is that in which the person is aware and there is no loss of consciousness. That one is called focal aware seizure because the patient is aware. And if the patient is not aware of the events or the patient lose consciousness, then it will be focal impaired awareness seizure. So focal seizure, there are two types of focal seizure in which one is in which there is no impairness of awareness, that will be called focal aware seizure, and in the other type is in which there will be impairment of the awareness. So it will be called focal impaired awareness. Focal aware is called simple partial as well, and focal impaired aware is called complex partial as well. Is it clear up to this point?
Yes.
Now you want to, they ask you to pinpoint the location of the seizure. So if there are hallucinations or automatism or deja vu, then temporal lobe. If there are movements, head or leg movements, then because the movement is controlled or the area of the control of the movement is present in the frontal lobe, so it will be frontal lobe. And if there is paresthesia, it will be parietal lobe. And if there is visual floaters or flashes, then it will be
Occipital lobe.
occipital lobe.
Okay, it's clear now. Thank you.
So this was some new piece of information uh, about seizures, which was not present in the lab case.
Sorry, one question about this Jacksonian march. Which is it like a motor or is it a non-motor?
Jacksonian march is an example of motor seizure.
Motor seizure.
There will be
So the
abnormal movement in distal part of the limb, such as in case of upper limb, The abnormal movements will starts in the hand, and then it will involve the whole arm, and then it can involve half side of the body or whole body. So it's
So,
kind of a march.
yeah, but where will be the lesion in this case?
As it started, you are
The
asking about the
lesion in
uh,
the brain, the
yes.
Jacksonian.
So you tell me if it's motor, then which part of the brain is involved?
It could be frontal lobe.
Yes. So
Mm-hmm.
frontal lobe lesion can result in, or
Mm-hmm.
frontal lobe seizure can result in Jacksonian march.
Okay, that's fine.
So yesterday we did amyotrophic lateral sclerosis. The second name for amyotrophic lateral sclerosis is motor neuron disease. Motor neuron disease can be caused by progressive bulbar palsy and other condition as well.
It's also called Lou Gehrig's disease, right?
Which one? Amyotrophic lateral sclerosis. You are talking about the other name of amyotrophic lateral sclerosis.
Yes, I think.
I don't have any knowledge about the second name of amyotrophic lateral sclerosis. So if it's a confirmed second name, then you can tell again so that everyone else can also remember this name.
Yeah, sure. It's called Lou Gehrig's disease. It's the person who I think found out about the disease.
Can you tell the spelling, please?
Lou and then Gehrig
Lou Gehrig's
apostrophe
disease.
S disease, Lou Gehrig's disease.
Yes, you are right. The other name for amyotrophic lateral sclerosis is Lou Gehrig's disease. So Lou Gehrig's disease or amyotrophic lateral sclerosis is the most common cause of motor neuron disease. Okay, we are done with multiple sclerosis as well. Now our next topic is bulbar palsy and pseudobulbar palsy. So we all know that a brainstem consists of, there are three parts of brainstem: midbrain, pons, and medulla. Like brainstem, the area of the brain that consists of pons, medulla, and cerebellum. Pons, medulla, and cerebellum. In other words, brainstem minus midbrain plus cerebellum is known as bulbar area. So bulbar area is basically also consists of three parts. One is pons, other is medulla, and the third one is cerebellum. What is bulbar palsy? Bulbar palsy is basically damage to the cranial nerve nuclei of cranial nerve 10, 11, and 12. So damage to the nuclei of 10th, 11th, and 12th cranial nerve will result in bulbar palsy. So how a lesion of 10, 11, and 12 cranial nerve will manifest? We all know that 10 cranial nerve or vagus nerve form a component of gag reflex, and it also supplies the muscles of the vocal cord. Cranial nerve 11 supplies the muscles of the neck, such as sternocleidomastoid, and cranial nerve 12 supplies the muscles of the tongue. So if you know the functions of these cranial nerves, you can tell what will be the Bulbar palsy, as there are damage to the cranial nerve nuclei of these nerve. So damage to cranial nerve 10 will result in the absence of gag reflex, and there will be bovine cuff. Bovine cuff is a weak cuff due to damage to the cranial nerve 10. And due to damage to cranial nerve 12, there will be wasted tongue with fasciculation. Because it's a lower motor neuron lesion, remember that cranial nerve nuclei and motor neurons that are present in the anterior horn of the spinal cord are lower motor neurons. So a damage to cranial nerve nuclei or alpha motor neurons that are present in the anterior horn of the spinal cord will result in lower motor neuron signs. So that's why in bulbar palsy, due to damage to cranial nerve 12, there will be wasted tongue and fasciculations will be visible on the tongue. Because there's damage to the cranial nerve 10, so there will be problem with phonation, such as there will be nasal speech. Now, what is pseudobulbar palsy? Pseudobulbar palsy, there is only one difference between bulbar palsy and pseudobulbar palsy. That in bulbar palsy, there's damage to the cranial nerve nuclei or lower motor neurons, while in pseudobulbar palsy, the damage is to the corticobulbar fiber. These are just like corticospinal fibers. Corticospinal fibers, uh, they supplies the alpha motor neurons which are present in the anterior horn of the spinal cord, and corticobulbar fibers, they supplies the cranial nerve nuclei. And the name indicates, they start in the cortex, and I already told you that everything that starts in the cortex and ends in the lower motor neuron, uh, they are involved in the control of the movements. So corticobulbar pathway is basically an upper motor neuron, is a part of upper motor neurons because they are bringing the message from upper motor neurons. So in bulbar palsy, there is damage to the cranial nerve nuclei. So lower motor neuron signs will be present, while in pseudobulbar palsy, because the pathway or the tracks are affected, corticobulbar track is affected or the pathway is affected, so upper motor neuron signs will be present. And what are the upper motor neuron signs? In lower motor neurons, the reflexes such as gag reflex will be absent, while in upper motor neurons such as pseudobulbar palsy, there will be exaggerated or positive gag reflex. The second difference, in lower motor neuron lesion, everything is lower or wasted. So there will be wasted tongue. If there is wasted tongue, then it will be bulbar palsy. And if there is spastic tongue without fasciculation, then it will be pseudobulbar palsy. So it's simple. In case of bulbar palsy, the criteria for the diagnosis of bulbar palsy is absent gag reflex plus wasted tongue with fasciculation. While in case of pseudobulbar palsy, gag reflex will be positive and the tongue will be spastic. Also, jaw jerk reflex will be positive as well. Let's do an example to make thing more clear. A 66-year-old male presents with difficulty in swallowing. So there is difficulty in swallowing because of the involvement of cranial nerve 10. There is no gag reflex. So the person is having difficulty in swallowing, and due to absent gag reflex, the person can aspirate anything he eat or drink. So he can develop aspiration pneumonia. So a 66-year-old presents with difficulty in swallowing, aspiration pneumonia, bovine cough, wasted tongue that sits in the mouth, and with fasciculation, difficulty to articulate certain words, nasal regurgitation of food. So is it bulbar palsy or pseudobulbar palsy?
Bulbar
Anyone?
palsy.
Why is it bulbar palsy?
Yeah, because the tongue is wasted and there's bovine cough and
Yes, wasted tongue with fasciculation. Bovine cough can be present in pseudobulbar palsy as well.
okay.
The things that are important to remember is that there is wasted tongue with fasciculation, which is basically a sign of because muscle wasting with fasciculation is basically a sign of lower motor neuron lesion. So this point is favoring bulbar palsy. Bovine cough is used to describe the non-explosive cough of someone unable to close their glottis, which is due to damage to the cranial nerve 10. And there can also be associated dysphonia because the person is unable to close his glottis. So the speech production will not be normal.
So if there is a question in which there is no distinction of bulbar or pseudobulbar palsy, and in the option it just they say that motor neuron lesion, and the other option. So can we pick just a motor neuron lesion as an answer?
Motor neuron lesion, both. So you're saying that they will give you the features,
A combined
generalized
features.
features.
Yes, and they are both mixed, and we cannot differentiate between bulbar and pseudobulbar. So can we then straight away pick like the option is just there is only one option which is matching is like a motor neuron lesion. So can we pick that?
If they give you a question like this, they will give you option of cranial nerve damage to cranial nerve nuclei.
Okay,
Then they will not ask about motor neuron lesion. They will mention something about cranial nerve lesion. So it's
okay,
important to remember the function of different cranial nerves,
okay,
so that whenever a question is asked, you can know that cranial nerve lesion are present. So if someone present to
right.
you with cranial nerve lesion plus hemiplegia or hemisensory loss, then what will be the diagnosis?
Brainstem lesion.
Yes, a brainstem infarct. If there is involvement of the tracts, then it is the most likely the lesion is the neurological lesion is in the brainstem area. Is it clear, everyone? Anyone want to ask any question up till now? So bulbar palsy is lower motor neuron lesion, and pseudobulbar palsy is upper motor neuron lesion because it involves the corticobulbar tracts, the tracts that supplies the cranial nerve nuclei. Uh, that is starting from cerebral cortex from the motor area. Now our Our next topic is obstructive sleep apnea. What is obstructive sleep apnea? Obstructive sleep apnea is intermittent and repeated collapse of the upper airway during sleep. Due to this problem, repeated collapse of the upper airway during sleep. What are the causes of obstructive sleep apnea? Obesity, alcohol, diabetes, hypertension. Uh, they are the common risk factors for obstructive sleep apnea. So, due to this repeated collapse of the upper airway during sleep, the person's sleep will be disturbed and he will have increased daytime sleepiness or somnolence and fatigue. And there will be morning headache as well. And another diagnostic point for obstructive sleep apnea is that the person will be snoring loudly at night. So a diabetic or a hypertensive or an obese or chronic alcoholic consumer who present to you with snoring at night and daytime sleepiness or somnolence and morning headaches, then you will think of obstructive sleep apnea syndrome. Initially, the initial investigation that you will perform will include pulse oximetry and alternate study of breathing patterns. And the most appropriate investigation for the confirmation of your diagnosis is polysomnography. Polysomnography is basically a study that is done in the laboratory. The person is asleep and is breathing patterns for the confirmation of the diagnosis of obstructive sleep apnea syndrome. So the initial investigation is alternate study of breathing pattern and pulse oximetry, and gold standard investigation is polysomnography. If you diagnose a case of obstructive sleep apnea syndrome, then you have two treatment options. If the disease is not that much rare, then you can manage it conservatively, such as weight loss and good control of diabetes and stop alcohol. But if the disease is severe or moderate, then you will need to use CPAP or continuous positive airway pressure.